Good afternoon and welcome to United TV and Bariatric Friday. My name is Kemal Erkan. Today we are going to tackle another really important topic for bariatric surgery, and this is a revision surgery. And if you ever wonder what happens if the first bariatric surgery doesn't work, in some cases, what are the options that patients have and what we can do at CRIAS and American Surgery Center is what we are going to discuss. And as usual, Dr. Irgau is going to join me to have this discussion with us, and he's going to answer our questions. Dr. Irgau, how are you doing?
I'm doing great, Kemal. Great to be back on yet another wonderful session.
Thank you. And the revision surgery is, well, we call it revision, but in some cases it can be a revision. In some cases it's just maybe the second stage. But this is a very important one for many of the patients. So what is bariatric revision surgery and how it's different than from the primary bariatric surgery?
So just like the word implies, you are revisiting, you're going back on a previous surgery. Essentially, a person has had previous weight loss surgery and they may have issues like the person has had gastric bypass and they've developed an ulcer now that is not responsive to medical treatment. That may require surgical treatment. And if we go back and take that ulcer out and redo the connection between the intestine and the stomach, that is a revisional surgery. Or another situation, maybe somebody has had a gastric band and that band has run out its course. The person requires a different type of weight loss surgery and we go ahead and do that. So essentially, revision surgery is surgery that is undertaken to modify or replace a previous bariatric procedure. And as you can imagine, by its nature, it's a more complex type of surgery, not only because it requires more understanding and experience on what that revision surgery should be, but also because technically it is a more challenging surgery because the surgeon is going back in an area where the anatomy is altered, scar tissue may be prevalent, so inherently it is more complex surgery.
Now, some of whom from gastric band to either sleeve or bypass. So the gastric band itself is not as invasive as the sleeve cases. So we have the band put on the patients, and we know that this was one of the first maybe procedures that we have done. So from band to sleeve versus sleeve to bypass, there are different levels of revision surgery. So I just want to kind of point out, not all of them are as severe as the others. So if someone is going from band to sleeve, that's not as complicated or not complex as if they are going from sleeve to bypass. Is that kind of true?
So it is a little bit more nuanced than that.
Okay.
For instance, the gastric band itself, although generally people view it as a completely reversible procedure because there is no cutting of the stomach or separation of the stomach from the intestine, the actual placement of the device itself does cause a significant amount of scar tissue, sometimes really altering the anatomy significantly. Not only that, but also the stomach where the band has been placed becomes much more thickened. So going back to do any surgery, whether it's a sleeve or a bypass, can be a very challenging procedure. On the other hand, when we're going from the sleeve to bypass, because the stomach has already been partitioned in part, it may actually sometimes be even an easier procedure than doing the gastric bypass originally because the stomach is already small. Okay. Now, each case obviously is different because everybody will have a different amount of scar tissue and different amount of alteration of the anatomy after their primary procedure. I think it is probably better to understand that any type of revision procedure where we are going from to a different procedure that requires stapling and suturing is inherently a much more complicated procedure. And that can apply to, band to sleeve, band to bypass, or sleeve to bypass itself.
So now, bariatric surgery is one of the most powerful tools to fight morbid obesity, and the outcome can be extremely good, and we have a really high success rate. With all these, the weight regain complications, some results not being so satisfactory may be happening. So what are the most common reasons a patient might need another surgery, a revision surgery?
So there may be complications that occur after the first bariatric procedure. For instance, as I mentioned before, a person who's had gastric bypass could develop an ulcer at the junction between the stomach and the intestine, which may not be responsive to medical treatment. A person who's had a gastric bypass may develop a stricture, which is a narrowing at that connection. Or a person who's had a gastric sleeve may have developed heartburn that has become less responsive to medications requiring additional procedure. So these are things that can happen after bariatric surgery. But also there is the issue of inadequate weight loss, so that the patient has not really achieved the weight loss that we have hoped for them to achieve. Now, the procedure itself may have a role in this outcome, but the patient himself or herself also may have a role in this. So yes, we do surgeries, revision surgeries, to improve the outcome. For instance, we may go from the sleeve to gastric bypass, we may go from the band to sleeve, or from band to gastric bypass, which are more complex procedures that may give the patient a better tool for them to lose weight. So in general, we do revision surgery either because the outcome has not been as satisfactory as we have wished in terms of weight loss, or because the patient may have developed symptoms related to some complications that can occur after bariatric surgery.
So revision surgeries are not offered lightly. So I know I read some of your notes, other surgeons' notes. We give not only different treatment options, but I see where we want patients to really follow through certain protocol before we take another surgery on them. And what's the way of evaluating these patients, whether or not they are a good candidate for a revision surgery?
So, as you correctly said in your introduction, these procedures should not be taken lightly, right? And certainly should not be the first line of treatment for whatever problem we are faced with, right? So if a person has an ulcer, for instance, the first line of treatment would be medications. If a person has a stricture, there may be other less invasive procedures that can be done to take care of that. For instance, we can do something called endoscopic dilation, where we actually can go, with an endoscope inside and use a balloon to stretch an area which has narrowed and is causing the patient problems. And similarly, if we are thinking about additional intervention because the person hasn't lost enough weight, or because the person has regained substantial amount of weight afterwards, surgery should not be the first thing we are going to think about. We have to review the whole situation, right? We have to be able to understand why that person has not lost enough weight, or why they are struggling with weight regain again, because the factors are multitude. It's not just a simple factor. So it's not a question of has this surgery failed the patient, right? We have to say, what was the role of the patient, their environment, their situations that could have contributed to this less than satisfactory outcome. So definitely revision surgery should be considered when appropriate, but it shouldn't be necessarily the first thing that we're going to jump into.
Right.
We have to consider many other issues, and we have to also, especially when it comes to addressing weight regain, we have to look at the foundations. So if the person has really lost focus, right, and they're struggling, well, what is to guarantee that that's not going to happen again, even with that second surgery, right? Are we going to go to a third surgery after that? So we have to address some foundational problems. So if, for instance, the person is struggling because emotionally they're having a lot of stress and they are looking into eating and consuming a lot of sugar to address that, that is not necessarily something that can be resolved by revision surgery by itself, right? We will need our nutritionists to be involved. We will need our psychologists to be involved. And we can address these issues. And we may still need to offer a revisional procedure, but at least we have some robust foundation, essentially, upon which we will have this second procedure.
So last week we discussed the social stigma. I mean, we kind of add side topics to social stigma, but under the social stigma title, we have a lot of other problems that patients are going through. And in my opinion, it's one of them is just like the specific issue of someone just again being judged because they failed. And we'll probably go into that maybe a little bit later, because that's one issue that that still bothers me in a way, that when we have a patient who is fighting with diabetes, they try so many different medications. They may be on 3-4 different medications. They may finally give up and then just be on insulin. And the trying and getting that under control is never being judged. But yet, when someone fails on the first surgery, somehow we are kind of just, well, not we are, but there's some negative, maybe prejudice against those, which is one of the things that we need to overcome. I mean, in my opinion, again. So, because not everything works for everyone. And so someone who had, which my next question is going to be kind of like, helping with the different, surgery types, which I need you to kind of educate us on that. But someone, again, with the band who had this 20 years ago may not have the most successful results, as other surgery options were not there available, right?
Absolutely,
So now, my next question. What types of revision surgeries are the most commonly performed today?
So the most commonly done procedures currently would be procedures that would change the gastric band to a different procedure. So, for instance, removal of the gastric band, followed by the sleeve gastrectomy, removal of the gastric band, followed by the gastric bypass would be one procedure that's done commonly. Another procedure that we do commonly also is switch the gastric sleeve to gastric bypass. That would be another procedure that is done more commonly. I do want to go back to the issue that you were addressing in your introduction before this last question, and that is, how do we define failure, right? Now, if we define failure pointing fingers either at the procedure or at the person, I think we have lost sight of something more important, and that is obesity by itself is the main issue. It's extremely complex. And not looking at that and trivializing obesity and then addressing the patient or the procedure as the main problem then misses the point, right? When we are dealing with cancer that has affected a patient, and we treat cancer as aggressively as we can, and down the line that cancer comes back, we don't point fingers at the procedures or at the patient. We point fingers at the cancer itself. Exactly. It is a complex disease. Let's address it. So when we are dealing with revision, and when I'm talking about what was the role of the patient in that failure, I'm not judging the patient. I'm not addressing the patient as somebody who is somehow responsible for that. What I'm getting at is, what are the various components of our treatment that are not strong enough to address obesity, right? So looking at obesity in this manner is extremely important, right? So very often it is very hard for patients to come forward and ask for a revisional surgery because they feel as if they're going to be judged, because they themselves also are falling into the trap of trivializing how complex and how intransigent obesity is as a disease. Once you understand that, then looking at a remedial treatment, whether it's counseling, whether it's medication, or whether it's a surgical procedure, then will be appropriate, and that will be looked at just like any other treatment.
So, some of these issues come up. We talk about failure, but then how we actually handle that failure in different places. Again, the social stigma is a really important part of understanding this problem itself. I had a friend maybe 15 years ago. She had some addiction problems.
Mm-hmm.
And she went for rehab. 1 month, $100,000 later, addiction was still there. So I visited her a couple times while she was there, and the issue was I saw other people, this was their 5th time, 6th time, 7th time, and they keep coming back because they're not able to cope with what's happening. The treatment is not fixing the problem, not being able to handle everything that needs to be. And that's kind of why we need to kind of forget about these issues, who's failure and who's not, and just focus on the treatment. And that's one of the freedom that other illnesses probably, I mean, I say this in a funny way, but just a lack of term. So other illnesses have this freedom of, they can be no social stigma, no prejudice, no nothing. You can fail and we'll try out something else. Don't worry about it. It's not you. But then we are still trying to get in there with, like, do we order medications for this weight loss? Well, yes. Do we discuss the surgery? Yes. Do we discuss the surgery again? Yes. You don't leave the patient alone until they respond back to you with what they want to do with this problem. Why are they coming to us otherwise? Right? So this is why I think this issue of the stigma is impacting morbid obesity in several different ways. And I do believe that that's one of our goals in these sessions, to overcome those issues. Now, I don't know if you answered my earlier question with most common. I kind of gave the spoiler earlier, but if you can just technically define which are the most common ones.
So the most common would be conversions of the lap band into one of what we call stapling procedure, either lap band to the sleeve gastrectomy, lap band to the gastric bypass. That would be a fairly common occurrence. Another relatively common procedure would be to convert the gastric sleeve into gastric bypass. As people may recall, with the gastric sleeve, the operation is limited to the stomach itself. The intestine is left intact. There may be situations in which we need to reroute the intestine and change that procedure into gastric bypass. That conversion from the gastric sleeve to gastric bypass would be such a procedure. There are other procedures also that we do. For instance, if there is a narrowing at the connection between the stomach and the intestine, like I said earlier on, resizing that stoma is another procedure that we can do.
Sure. And is this more risky? Well, I'm assuming the answer is kind of yes, but if you can elaborate that, why it's more risky?
So, yeah, definitely. If you look at all the potential complications that can happen after the initial procedure, for instance, if you take the gastric bypass or the gastric sleeve, we talk about the potential for bleeding, the potential for leaks. For instance, if the divided stomach or the reattached stomach to the intestine, if that connection doesn't heal very well and substances leak out, that's called a leakage that can cause a serious infection. Those potential complications are actually at a higher incidence level when it comes to revisional surgery, right? So if the incidence after, an original sleeve gastrectomy for a leak is, let's say, less than 0.5%, after a revisional procedure, it could go up to 1%, for instance. So clearly much more challenging procedures that are generally undertaken by experienced centers. And as you know, CRIAS has been doing bariatric surgery now for almost 25 years now. We're just about to hit our quarter of a century now, right? And we have a lot of experience with not only primary procedures, but also revisional procedures as well.
So I'll tell you something kind of interesting that happened last week in our ACO case conference, not on the ASC, but ACO.
Yep.
When we go through those, our nurses make their presentation, the morbid obesity, diabetes, chronic kidney, cardiovascular, psych, social determinant of health. Those are kind of our focus. Sleep issues with COPD. So those are like 6-7 main focus that we have. So when I see there was a patient BMI was 47, and when the nurse said, well, they did have bariatric surgery, so that's why I'm actually putting a revision, perhaps. Well, what she actually, I'm sorry, she put a bariatrician order, non-surgical medical help. So I immediately checked, it was one of our patients. So I immediately checked her time of the first surgery, and her BMI was 64. So the failure that we talk about or we define here is not actually a failure. So this patient still was able to go from 64 BMI to 47. Now, I didn't check her actual weight, but there's a lot of...
That's a significant amount of weight.
Right.
Yeah, absolutely.
So now patient is ready to take this. She did this with band. And now she wants to do more. And then I had to kind of point out to our nurses, I'm like, this is what we discussed, what we are saying. So you may think that the first surgery didn't work, but that's not the case. So this patient has already 17 BMI points, less than they started several years ago. So that's by itself a huge success.
Definitely.
So we kind of, need to look at it from different perspectives and have this 360 approach to make sure that it's understood very well, because not every morbid obesity is the same.
Absolutely.
So
Absolutely.
it can go from 35 to 70, 75 BMI, and that's a huge spectrum from several different points. Now, what's the way of patients' understanding of, this is the time, perhaps it will work better? Now, just earlier example I give you, if we keep those already initial success stories, but just looking at someone who really didn't see a good result, what are the things that they can expect after the revision surgery?
So one of the interesting things that I emphasize after revision surgery, particularly if it's being done because the weight loss was not as satisfactory or because there has been significant weight gain afterwards, is that yes, the second procedure may be much more powerful in terms of its input. But one thing that patients need to understand is that the second round of weight loss may be much slower than the initial procedure. Right? This is important because if the patient, for instance, has had a procedure years before and they experience a drastic weight loss in the first 6 months, which is what usually happens after bariatric surgery, now their expectation needs to be different, right? We have to really make them understand that the weight loss will occur much more slowly. And if they understand that, then we can keep them motivated through the process as well. There's nothing worse than for a patient to lose motivation through the process, right? If they lose motivation, we lose everything essentially, right? And to keep them engaged, we have to make them understand that the weight loss this time round could be slower. And it's okay, right? I mean, sometimes we treat weight loss as a sprint rather than a marathon, right? It's important to look at the long-term outcome rather than at the short-term quick weight loss. And particularly when patients are looking at revision and where they are investing this much in terms of emotion, in terms of also concerns that they may have about going revisional surgery, it's important for them to understand what the outcome will be. Very often, if we're doing these procedures because there have been symptoms like heartburn, for instance, or an ulcer that is not responsive to medical treatment, actually the quality of life improvement is significant. Patients who had significant heartburn will see that the heartburn really is resolved after the revisional procedure, or if they were having a lot of pain from the ulcer and that was not responding to medical treatment, they will find significant improvement afterwards.
Absolutely.
Yeah.
So my final question, we kind of got into this a little bit. Other than social stigma, there's also self-consciousness of, well, I failed and I shouldn't be doing another one. I shouldn't go back to the surgeon. Some patients, they are discouraging themselves and trying to talk themselves out of a second surgery option. So what advice do you give them for those patients? What do they need to know before they decide whether or not they should be doing this?
Absolutely. I think we need to have an honest conversation with the patient about where they were, where they are right now, and how can we get to a place that they are looking for, right? It is important to throw judgment away from this, right? This is a medical conversation. It's not about somebody failing, somebody not failing. We have to look at obesity, as I said, as a complex disease where the reasons for the weight gain are multifactorial. There are several factors really interacting to bring the patient to their current position. And we should be there really to help them clarify all this. And then, from then, obviously, we discuss what is the role of changing lifestyle, for instance. If the patient was struggling with a certain with a certain type of food, how can we get them away from that? What help we can get them? Rather than scolding them, oh, you have done this or you have done that. That's not our business doing that. We are there to provide solutions, understand the problem, first of all, and then to provide the solutions, right? And if revision surgery is part of that solution, we're not going to shy away from discussing that, with the patient. And ultimately, the patients will have to understand the implications of our treatment proposal and then either go with it or, tell us what they think. But it is our role to educate them about the different options that we have for treatment. And if revision is one of them, obviously we have to present that. But at the same time, as I said, we have to look at the different components of the problem, right? Yes, improving the power of the surgical procedure will bring its own benefit, right? If we had a gastric band before, bringing a more powerful procedure like the sleeve or the gastric bypass will significantly impact their ability to lose weight. But at the same time, were they making the right choices, right? Were they having enough counseling? All these issues also we need to honestly discuss with them and make sure that they are addressed as well. Again, as you said, and as we've mentioned earlier on, it's important to understand that obesity is a disease. It should be treated as one. We are a treatment center that should be providing all potential treatment options to the patient, right? And this takes that stigma away, that judgment away. Unfortunately, obesity seems to be a disease where many people can show their stigma or their prejudice without any repercussion. Even insurance companies do that without any problem, right? We come across some insurance plans where they may say, okay, we're going to cover one bariatric procedure per life. I mean, if you understand that obesity is a disease, you will let the clinicians take care of the problem in terms of what treatment is necessary. You cannot say, okay, we will give you this tablet, and if this tablet doesn't work with you, then all doors are closed and you will be condemned to suffer with the disease. Insurance companies should not have to be able
Or
to say that.
the government shouldn't be doing
Exactly.
this.
And
Yeah.
the reason they are able to do that is because, again, it is acceptable to discriminate against obesity without any repercussions.
Absolutely. So, for those who's out there, one of the issues that I can tell you, we do these programs. One earlier was usually it's about 40 to 50 minutes, and we spend about 30 minutes on this, and maybe another 2 hours I do prep for the entire week. So that's 4 hours in my 80 hours workload that I have. So work hours that I have. So this is not, it's not like I'm going to do another shooting after this one. We are hands-on. Hands-on in a way that we have our case conferences. You join our surgery center case conference with our bariatric patients. Outside of that, I have our ACO case conference. And what we have seen is patients kind of pushing, not just for morbid obesity overall, like, lately with the colorectal and colonoscopy cases, I want to make sure that I do some cross-check with what our team is doing. So I make phone calls directly to the patient. So that's what I was trying to justify earlier by saying, this is not what I do all day. So this is maybe 4 hours in the entire week. So I call patients and I see like they need to repeat the colonoscopy in 1 year. They're already 8 months behind. So it's a huge issue for cancer. And I see the patient that missed their 3-year follow-up. Not everyone needs to do 3-year colonoscopy. That means there is a potential risk. We call 15 times and they're not answering or they're not talking. They do, however, answer my calls because I call from my own cell phone. So I think when they see the number, they know that this is not a spam or it's not the office call. So what I'm trying to say is that patients do kind of take their time to just wait until there's some emergency. And in the cases of like colonoscopy, I tell our nurses, I'm like, okay, if the patient has hemorrhoid and if needs an operation, trust me, you don't need to call them 6 times. They will be in our office next morning.
Knocking, right?
So in bariatric, on the morbid obesity side, we don't have that type of urgency, like acute urgency, and that's one of the reasons that patients may be not seeing this as a huge problem until it becomes a really big problem that impacting so many other parts of our body.
Absolutely.
So the worst thing you can do to yourself is start having a discussion with your primary care, with your dietitians, which we have 5 full-time available right now. Bariatricians, we have 3 of them in ACO network, and also our surgeons. We are also not just for the surgery, but if the patient is not ready for it, we are providing options on medications as well. So that's the worst thing you can do by start looking this the help that you need immediately, and make sure that you get educated with what's available for you out there. Watch our videos, understand what you are going through and how this is impacting your life. So, Dr. Erkan, thank you again for joining us.
You're welcome. My pleasure.
This was a good session, and I know the other thing that we have our playlist on YouTube, specific playlist for specific topics. We may be covering certain things in a certain way, but if you watch 3-4 of them, you'll have a really good idea. This is better than any other education you can get from anywhere else in the world. So all of them are there available for our patients. Please get the help that you need. We are here. And until next week, stay united. Bye-bye.
Thank you. Bye.